Hello everyone. So in this video we would be looking at the topic recurrent miscarriage. So let's look at the definition first. So it is defined as occurrence of 2 or more consecutive spontaneous abortions before 20 weeks of gestation as documented by either sonography or histopathology. So 2 or more before 20 weeks of gestation either by sonography or histopathology. So earlier definitions by RCOG or ESHRE considered 3 or more consecutive miscarriages before 24 weeks of gestation. Now we have reduced the limit and by making it 20 weeks of gestation, and also this one has been reduced. So 2 or more rather than 3 or more. So incidence: 1% of women of reproductive age. Risk increases with each successive miscarriage reaching 30% after 3 consecutive losses. So that is about the incidence. Coming to etiology. So the causes of recurrent miscarriages are multifactorial and often obscure. Factors may be recurrent or non-recurrent. They may be either classified into first trimester or second trimester causes. So first trimester abortion causes, there are 7 of them, and second trimester there are 4 of them. So we look at first trimester first. So genetic factors, we look at the headings first. Genetic factors: endocrine and metabolic factors, PCOS, infections, inherited thrombophilias, immune factors, unexplained. So first one, genetic. Parental chromosomal abnormalities, particularly balanced translocations. Couples with balanced translocation have miscarriage rate greater than 25%, but successful pregnancies can occur in 40 to 50% of the cases. So greater than 25% is the risk, but successful pregnancies can occur in almost half the cases. Next, coming to endocrine and metabolic, let's see translocation. So balanced translocation is something very important. This one, it's seen almost everywhere. Let's look at it. So here you can see how balanced translocation looks like. So same thing has been interchanged. So that is what balanced translocation is. So just for completion's sake. Endocrine and metabolic factors. Poorly controlled diabetes increases the risk of early pregnancy loss. Thyroid antibodies are often associated with miscarriage risk though their role remains secondary to broader autoimmune dysfunction. So one is a diabetes, the other one is thyroid autoantibodies, but we know it is because of autoimmune dysfunction. Luteal phase defect with insufficient progesterone production can affect implantation or early phase or early pregnancy maintenance. So let's take a look at this, because this is somewhat I have repeatedly seen this particular concept. Luteal phase is a condition where luteal phase is insufficient to support pregnancy due to inadequate production. So here it is. So insufficient corpus luteum function, which leads to low progesterone, which leads to poor endometrial preparation seen in anovulatory cycles, PCOS and perimenopause. So rest of the things shouldn't matter much, only the first luteal phase defect, this one. Luteal phase of menstrual cycle is insufficient to support the pregnancy. Insufficient progesterone. Next, coming to the PCOS, polycystic ovarian syndrome. So exact mechanism is unclear. Elevated LH, insulin resistance and hyperandrogenemia are contributing factors, but exact mechanism is unclear. Coming to infections, genital tract infections like bacterial vaginosis may increase miscarriage risk, although their role in recurrent miscarriage remains inconclusive. So bacterial vaginosis. Inherited thrombophilias like protein C resistance, factor V Leiden mutation, antithrombin, in this particular case, antithrombin 3 deficiency, hyperhomocystinemia can cause placental thrombosis. So this one is generalized, everywhere it can cause thrombosis, like when heart problems, myocardial infarction at a young age, stroke in the young, this one is a cause. Causing placental thrombosis leading to recurrent loss. So protein C resistance, antithrombin 3 deficiency, hyperhomocystinemia. Immune factors. So we have already seen how autoantibodies against thyroid can be there. Even over here, autoimmune, so anti-cardiolipin, anti-DNA, anti-phospholipid can cause recurrent miscarriage, and there is a specific syndrome, anti-phospholipid antibody syndrome, which involves anti-cardiolipin antibodies and anti-beta 2 glycoprotein 1, leading to placental thrombosis and vascular necrosis. So, anti-cardiolipin antibodies and anti-beta 2 glycoprotein 1, leading to placental thrombosis and vascular necrosis. And then there is alloimmune, the dysfunction of uterine natural killer cells and placental and parental HLA sharing. So, UNK cells, no UNK cells, parental HLA sharing may play a role, though the evidence remains unconclusive. So, that is about alloimmune, UNK and parental HLA sharing. Finally, coming to the unexplained causes. Despite extensive investigations, almost half the cases it is unexplained. So, with this we have covered the first trimester abortion causes. Let us repeat them. Genetic causes where translocations are seen, endocrine where we look at diabetes, thyroid antibodies, luteal phase defect, PCOS where we talk about LH defects, LH levels, insulin resistance, hyperandrogenemia, infections where we talk about bacterial vaginosis, inherited thrombophilias where we talk about a couple of them, immune factors where we talk about autoimmune, anti-cardiolipin, anti-phospholipid antibody syndrome, and alloimmune things, related things. And then finally unexplained causes. Coming to second trimester, so anatomic abnormality. So by second trimester the body is formed almost. So anatomical abnormalities could be a cause. So congenital or acquired or cervical incompetence. So first one, defects in Mullerian duct fusion, bicornuate, septate or unicornuate uterus account for many structural causes. So Mullerian, as we all know, gives rise to the female genital tract, unlike the other one, which is was it Wolffian. Wolffian is for males. So Mullerian gives rise to females. So defect in that can lead to these, which can be cause of second trimester abortion, because it needs a space to grow. Proper uterus is required for fetal growth. If that is not working, then you have fetal demise. Acquired conditions like uterine fibroids, intrauterine adhesions or endometriosis. So that is another thing. And cervical incompetence, inability of cervix to maintain pregnancy leading to second mid trimester loss. Then there is chronic maternal illness, uncontrolled diabetes, SLE, chronic renal disease, hemoglobinopathies. So all of these things. So conditions like uncontrolled diabetes, SLE, chronic disease and hemoglobinopathies. So that is chronic maternal illness. Next, coming to infections. There it was bacterial vaginosis. Here it is syphilis, toxoplasmosis, listeriosis. And finally unexplained. Many of them are unexplained. So second trimester will repeat them. Anatomical causes where uterine defects, congenital ones, and also uterine defects but acquired ones like fibroids, adhesions, endometriosis and cervical incompetence. Then there is chronic maternal illness. Then there are infections, unexplained causes and all that. Coming to investigations, a thorough history, clinical examination and appropriate investigations are essential to determine the underlying cause. So first we look at history examination, then we look at diagnostic tests, and under diagnostic tests we have quite a few of them. Coming to history and examination, detailed history of previous pregnancies including gestational age at miscarriage. You need to know that, to put it under one of these. Then there is histopath or karyotyping if concept of the conceptus if available, because even that is this thing. If it is some kind of weird anomaly of this one of chromosomes, the fetus it can't stay alive. It is incompatible with life. Any chronic medical illnesses or autoimmune. So here we have seen how autoimmune conditions, where is it? Here how these are responsible for first trimester losses. Any chronic medical conditions, we covered that. Diagnostic tests. There is genetic testing, endocrine evaluation, infectious screening, immune and thrombophilia screening, and anatomic evaluation. So genetic testing, karyotyping of both partners, and products of conception to detect chromosomal abnormalities. So that is one, karyotyping of both partners and the products of conception to check for this. Yeah, if chromosomal abnormality is identified, because like after that, pre-implantation genetic diagnosis (PGD) or donor gametes may be recommended. So pre-implantation genetic diagnosis or donor gametes. Let's look at this. This seems interesting. Like just to ensure that we know what it is. Like it shouldn't be something like we know most of what it is written here, but some things we need to know what it means. The technique used in IVF to screen embryos for genetic diseases, ensuring healthy embryos. It helps prevent transmission of inherited genetic disorders in couples at risk. So yeah, so the same thing, like it is diagnostic this one, but this is the treatment mostly. Coming to endocrine evaluation, there are thyroid function tests, blood glucose, serum LH, progesterone levels. So we have heard about luteal phase defects, yes, that is for this one, and thyroid function to detect hypothyroidism, autoantibodies, blood glucose for diabetes, fasting and postprandial, serum LH on day 2, day 3 and of the cycle to identify PCOS. Then we look at infectious screening, VDRL for syphilis, toxoplasma, IgG, IgM screening and endocervical swabs for chlamydia, mycoplasma, bacterial vaginosis. Yeah, next coming to immune and thrombophilia screening. So lupus anticoagulant, anticardiolipin antibodies for antiphospholipid antibody syndrome, lupus anticoagulant, anticardiolipin. Then there is protein C, protein S, antithrombin 3 for inherited thrombophilias. And then anatomic evaluation, ultrasonography to detect uterine malformation, polyps, fibroids and ovarian cysts. So uterine malformations, polyps, fibroids and ovarian cysts. Hysterosalpingography to assess cervical incompetence, uterine synechia and structural abnormality. So HSG for that. And hysteroscopy and laparoscopy to detect visualization, to detect for direct visualization and correction of anomalies. Sorry about that. Yeah. So again, anatomical, this one. Yeah, these ones are fine. This one is anatomical, ultrasonography for uterine malformation, polyps, fibroids and ovarian cysts. HSG to assess cervical incompetence, uterine synechia and structural abnormalities. Hysteroscopy and laparoscopy for direct visualization and correction of anomalies. So we are done with the causes and investigations of recurrent miscarriage, which is like only these parts, the definition, causes and investigation. These are important for this particular topic. So I have included only that, but if you would like to read more, you can read upon it, because you can't tell 100% only this thing is coming, but based on previous years only these things are mentioned. So that's it. So in case you like this particular video, you can like it. In case you would like to suggest something, you can do it. You know the channels where you can do so. One more thing, I am wearing the same shirt because I am recording all of these videos continuously. So even next few videos I will be doing it continuously, and rather than having something like that made easy series where I have one huge video of 3 hours, I'm focusing on making it short sized. At the end of every video I just say I have ended the video or something of that sort, and just clip it and just upload it, but it will be on different days, so that, because even during exams most likely I won't be able to upload. So that is something I am keeping in mind. So thinking about that, I am batch creating videos so that it gets uploaded every single day, but videos are not particularly required because this content is so good. So if you would like the videos, you will have to wait. So it will be there every day coming up, but you won't be getting the made easy, because I have seen the analytics, because people wouldn't watch such long videos, and it's very hard to track and all that, though I am planning to add the timestamps, but it might take some time. Anyways, bye bye. And also, selfish reason, the number of videos on the channel might be high, so that is another thing, but I'll see. In case if it is possible, I'll make very long hour again, because that is what exactly I am doing right now, but in gaps, meaning cutting it, editing it. Okay, bye bye.